Welcome to our live webcast, My Child's Shoulder Dislocated During the Game, In-Season Management of Shoulder Instability in Football Athletes. Thank you for joining us. My name is Eric and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event evaluation. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. We are joined today by our speaker, Dr. Andrew Willis, dual fellowship trained sports medicine surgeon. At this time, I would like to turn the microphone over to our speaker, Dr. Willis, for opening remarks.
All right, can you hear me?
Yes, we can.
All right, excellent. Thank you. Thanks for having me. Sorry that we're a little late, a little technical difficulties, and a little jet lag from coming back from our Jets game in London, so still trying to get on, the right time frame. So this talk is somewhat appropriate for this time of year for a lot of you to take care of athletes, especially in the fall, contact athletes, schools, colleges, and so forth. And so we thought that this might be a good topic to discuss because it's not so straightforward. There's some nuances that still need to be worked out in terms of getting consensus statement as to what the best strategy is to address shoulder instability in a young athlete, contact athlete, particularly during their season, which is a little different. So my thought was to go a little bit over the concept of stability in the shoulder and some of the main concepts outside of in-season management, and then circle back and try to apply it to the athlete that wants to continue to play despite an episode of instability of the shoulder. What do we know and what can we apply to that situation that in an algorithmic way we can discern what the best treatment strategy and recommendation is for that particular person. So with that, we'll get started here. I have nothing to disclose for this talk. So overview, the glenohumeral joint is the most common large joint in the body that's dislocated. And why is that? Well, it certainly has the greatest degrees of freedom and range of motion. So it's not constrained. So as a result, it's susceptible to trauma and instability. Anterior traumatic instability of all shoulder instabilities is by far the most common, and it's between 80-90% of all instability events. Most commonly, or the most common group that it affects is male, young collision athletes. Contact collision athletes will be using as a term for certain sports. If you look at the NCAA injury surveillance system, you get an idea of the incidence. It's about 0.12 in 1,000 athletic exposures, with the three most common activities or sports in terms that make up the majority of those injuries is wrestling, as you see there on your left, and hockey, followed by football. And interestingly, for the athlete that's participating, these instability events, at least half the time, lead to a significant or substantial time away from the game. So in this one study, greater than 10 days, almost 50% of people were lost to participation. And that's a lot when the season's short. Football, this is where I was just 2 days ago, playing on this very hard turf that kind of comes in and out so that the grass field for the soccer team can play in London. And it's a common, unfortunate event that shoulder subluxation and dislocation instability occurs in football quite frequently. And depending on the position, age of the patient, and other circumstances, there really is different ways to treat it. So we're going to focus a little bit on football as the topic for collision and contact athletes, but it does apply to other sports as well. In football itself, if you look at the NFL Combine, a few studies looked at just how common shoulder instability is amongst all their injuries. And in one NFL Combine, shoulder injuries comprise the second most common body part for injury. And 24% of the shoulder injuries were actually instability events. And 50% of all shoulder procedures in those 350 elite level college athletes invited to the Combine had previous shoulder instability procedures. So it's not an infrequent thing. Looking at another Combine analysis by Rob Brophy, about 10% of all athletes within the Combine do have a history of some sort of instability event, procedure, or intervention. And if you look at the NFL, those that are taken on a team or drafted or free agents, incoming players, about almost 5% have had prior surgical procedures. And in that one article, it does have an impact on longevity, particularly for linebackers and certain linemen in the NFL. So not an uncommon event, and something we all probably encounter, especially in the high school and college levels, and we need to sort of have a unified approach. What is the best evidence-based approach? I think that begins with classifying what we're talking about. So there's a spectrum of instability, starting from micro instability to what we think of as macro instability events. But you really have to think about instability as a dislocation, which is a complete dissociation of the two articular surfaces, the humerus on the glenoid. So it completely comes out and requires a manipulative reduction. So when we define and talk about a dislocation, that means that the two surfaces have separated and they need to be manually reduced. So that's a true dislocation. A subluxation is defined as a sort of translational event that is at the edge of the physiological limits of the joint. It doesn't come out, so there's some maintained contact, but it's outside the norm. And so both of those are incorporated into a lot of these studies in terms of understanding what we're talking about. And I think it's important because it's going to come back later to factor in decision-making, because, well, they're related, they're not exactly the same, and the prior history or the actual event that you're evaluating is going to be influenced on understanding that definition. The anatomy of the glenohumeral joint is such that, as we said before, there's minimal bony restriction. That gives it maximal mobility, so it's very unconstrained. I like to think of it as a golf ball on a tee. There's not a lot there, like in a hip socket, that's holding it in place. When you dislocate a shoulder, is very different than when you dislocate a hip. And so it contributes not a lot, but a little bit to the overall stability through retroversion. So what does contribute to shoulder stability? Well, it's important to know this so we understand what's injured and what needs to be fixed, if anything. So inherent stability relies heavily on soft tissue. Includes two things: the static stabilizers, which are the capsule, labrum, and glenohumeral ligaments. And you can see that on the left, blue are the ligaments, and the red labeled is the dynamic stabilizers, which you see on the right here is the rotator cuff musculature. So that helps stabilize as well. And those are important anatomic structures that contribute. I think of the glenohumeral ligaments much like this picture here, like a sling, like a hammock. And if it becomes detached, well, you can imagine you may be able to kind of hang out in it, but have to work at it. If you move at all, you kind of fall out. So that's sort of the concept I use when I talk to patients. So what is the pathoanatomy of injury? What is injured? So the essential or primary lesion is what we call the term the Bankart lesion. And that just means a capsulolabral avulsion. So the connection, as you can see with the arrow where it says Bankart lesion on the left, it's the capsulolabral attachment to the anterior inferior glenoid rim. And the picture on the right is looking down from front viewing portal. And you can see that the bone looks fine, and that rim of labrum or bumper with the attached capsule is pulled off. So it's important to know what's injured, where, and what, because that's going to play a role in terms of understanding how to address it. And multiple studies have shown that a first-time traumatic anterior dislocation, this is injured in about 97% of the cases. And interestingly enough, with a traumatic anterior subluxation, very similar numbers. So we tend to think of the categories as different, and they are to some degree, but they're not far off. In terms of what else is injured, well, we always think of the Bankart lesion, but there's so much more instability and understanding of instability, and secondarily, how to address it, what procedures are best, and what will give you the highest success rate in terms of lowering recurrence. It really, the focus has been on the osseous anatomy, really, really important, and a lot of research came out recently discussing not only injury to the glenoid rim, but also the humeral head. So these are very commonly associated pathology that are important to recognize because they influence success rates. So the bony Bankart on your left is an anterior glenoid rim fracture, and like a golf ball and a golf tee, that has a significant impact on the stability. Just that little lip on a golf tee, the golf ball doesn't stay so well. And the Hill-Sachs lesion is a corresponding lesion on the lateral side of the humeral head articular surface, where it's a more cancellous bone that gets impacted on the hard cortical bone of the anterior glenoid rim. And so you get this sort of impaction dent, like when a car is hit from the side and the quarter panel is dented in. And that does have significant ramifications in terms of stability procedures, recurrence rates. We'll get to that in a second. The Hagel lesion, the humeral avulsion of glenohumeral ligaments, is also very important. About 9% of cases have that. But that has a very, very high failure rate treated non-operatively. And so it's important to recognize that, because that's one that you don't want to miss or you won't have success. And the best way to see that is the J sign, where you see that arrow, that yellow arrow, outlines the capsule. It's pulled off the humerus and just sort of ends at the end of the arrow. It comes down like a J, the black line right here. I don't know if you can see the cursor, but it comes down and ends. And if you get an MRI early, which I tend to do because it's very important to understand all the associated pathology early, you almost have an arthrogram from the edema. And so you don't need to do any dye injections. But it does help outline that, and that's important to recognize. The Alps lesion, the anterior labral periosteal stripping avulsion, is sort of like when the whole complex just gets peeled, like wallpaper peeling off the wall, off the front of the glenoid. You see with that little white arrow. And that also is important to recognize as well. It looks very different than just a detached labral tear, but it has implications on stability if not recognized. And lastly, the GLAD lesion, which is the glenoid labral articular defect. And why that's important is because that's been associated with progressive arthritic change. And that's a concerning lesion, and one that pushes you to address this pathology earlier, because it is associated with a higher rate of arthritic progression. So those are the key associated structures that can be injured. So let's get to the natural history. It's important to understand the natural history so that you understand why you're doing something. We have to understand what it's doing, this injury. If you have an injury, it doesn't change the natural history, then you don't need to do much to change it. However, if you look here, there is a very, very high rate of recurrence in the literature. And this is the highest in young athletes in contact sports. It's like inversely proportional to age. Several classic studies, this is the Westbourne Cadet study, looking at military cadets because they are in a closed system, easy to monitor, every event is recorded. And a first-time traumatic anterior dislocation had a 92% recurrence rate. That's quite high. In a cohort of 15 to 20-year-olds, Robinson reported 87% recurrence. Mazzacca looked at under 20 and said essentially 95 or greater. And in skeletally immature open growth plates, back in 92, a study had a complete 100% failure, leading one to believe that the younger you are, especially that young, this was under 13, I think, that it's an automatic. That's being rethought a little bit, but nevertheless, these are very high numbers. And so when you have this sort of natural history, the question is, how can it be altered and when? So recurrent instability. The concern really is the risk of cumulative damage to the soft tissue and bone. When it keeps happening, what are the consequences? Are there any consequences? Why should we be concerned? Well, this was kind of a landmark study. This won the Neer Award in 2009. And basically, it was a 25-year follow-up on these 227 patients that he had been following, published multiple series on these patients over time to give us a lot of good data. But this was a key because the 25-year follow-up was looking at radiographic changes, and moderate to severe radiographic OA was the outcome. And those in the cohort that had no recurrences, right? No recurrences after their initial had an 18% incidence of moderate to severe radiographic osteoarthritis at 25 years. If you had 1+, so one or more, or over one, so 2, 3, whatever, it was almost 40% at 25 years. That is concerning. That's a big difference. So this is the first time that that evidence sort of was published, as well as a landmark study, that there is progressive radiographic changes and cumulative damage from recurrent dislocation. At least that's inferred. So if you look at more recent studies, this was in 2006, under 282 patients under 40, they looked at they got pre-op CT scans just to kind of quantify the degree of arthritis on first-time dislocators, no previous surgery, no interventions before they were going to surgery. And what they found is that of these patients, 31.2% had radiographic on CT osteoarthritic changes. And these changes, the ones that had the changes, it correlated directly with the number and frequency of instability events. So further information that has come out to support that recurrent instability is not benign. Lastly, this is a very important study done by Owens, who was at West Point, and now he's at Brown. He did a lot of classic studies, a very, very good studies, looking at, and this is the most recent one, looking at 714 patients. He really assessed glenoid bone loss by CT, the best and most accurate way to do so, and wanted to see if there was a difference, just scanning first-time dislocators versus recurrent dislocators, in the amount of bone loss on the glenoid, and found a substantial difference. 6.8% bone loss, the width that you can see of the glenoid, and that increased dramatically with multiple recurrent instability events. And so the concern really is, is that this is a significant enough concern with the bone loss that's going to influence what you can do. And so doing something early, because it changes, you see later, will change what procedures can be done. And so getting it early may be advantageous because that's a significant negative, the bone loss. So if we, and again, bone loss correlated with instability events. If you look at overall, I think consensus on the literature for management at this current time for instability, operative versus non-operative overall, the superior results for operative intervention. Surgical stabilization reduces recurrence and improves return to sport. As one study on 13 and younger, recurrence rate in a non-operative was 70.3 versus surgical recurrence at 13. Dickens also was at West Point, about a larger study looking at a recurrence rate surgery versus non-surgical, not only for the index season, but for the following season. So those that went back and then those that never had surgery at the end of the season and went back again, only 40% or 40% return to play. It's a low number as opposed to those that had surgery at the end of the season and played the next season. 90% played. So it's a big difference. And then this one meta-analysis looking at overall recurrence rates in surgery versus non-surgery patients found a significant positive effect for surgery. So I think overall the consensus is surgical stabilization is superior to non-surgical stabilization. If you look at the literature in terms of arthroscopic and open techniques for collegiate athletes, there's some debate, but overall with newer techniques, suture anchors, using more than 3, putting in the right spot, down anterior inferior, and maybe adding posterior, that there really wasn't a significant difference looking at this systemic review. We're about 8.5% recurrence for a scope Bankart procedures versus open shifts. And again, this doesn't include bone loss. And so what is important is that the technique for surgery changes dramatically by bone defects. It's influenced significantly by lesions on the humerus and the glenoid. So that's why all attention is now on quantifying and understanding bone loss, because failure rates correlate. Soft tissue procedures for bone defects of certain sizes are automatic, not going to work. So what to do? Getting back to the topic here is, all right, so with that background, what do you do when you're taking care of a high school team and someone that wants to go on and play college and is a good athlete and they go on to the playoffs and they dislocate their shoulder and they want to come back? What do you tell them? Should they come back? Should they not come back? Should they do early surgical intervention? Can they go back and play and do something later? Or do they ever have to do anything? So that's a real question. And so the way I look at it is I ask the question, can a player safely attempt to finish a season after a instability event? And that includes dislocation and subluxation. What's the success rate of going back in the same season? And what are the risks? And we have some background, and I think we understand what it probably will be. But what do you tell your athlete, especially if they want to finish out the season? It's their senior year, they won't be able to play again. And I think you balance that with what can you do at the end of the season, or what should you do at the end of the season if they actually make it through the season with non-operative treatment? Do you fix them? Do you not fix them? Do you keep watching? So that's what we'll attempt to address. And so let's go to the literature to see if we can figure this out. And there's not a lot of studies about in-season management, but the first one, believe it or not, was not long ago. So Dan Buss looked at high school athletes, and it's out in Minnesota, and he did no immobilization, immediate range of motion, strengthening as soon as they had pain-free range of motion, to call it accelerated rehab protocol, brace plus or minus, and back in. And he reported 87% of his athletes were able to get back same season. But being able to get back, return to play, doesn't always tell you everything. But they were able to play, and they were able to get back an average time of 10.2 days, which is, very quick. And it used to be thought that it was 3, 4, or 6 weeks, who knows, before you can go back. To show that you could have success going back. But I would point out that what is success, because I also reported that there were 1.4 episodes of recurrent instability per athlete during their time back. They finished the season, but they had recurrences. So going back, having a recurrence doesn't necessarily mean failure to keep playing. But what does that mean, and is that important? So looking at another study of 45 collegiate athletes, this is collision athletes at college level versus high school, and seeing what could be accomplished with a similar rehab protocol, minimal immobilization, pain, when he had good range of motion, pain-free, lack of apprehension, and good strength, went back. And overall, he was able to get 3 out of 4 athletes back in the same season on average 5 days. Of those that went back, 50% reported a recurrence. And of those that went back, 1 out of every 2, so 50% actually finished the season. If you had a subluxation as your initial event, as opposed to a dislocation, you have about a 5.3 times higher chance of returning successfully to playing the same season versus a dislocation. So subluxation seemed to be able to get back more successfully. Same authors again looked at now the same group. Those that didn't finish the first season, had surgery, went back for the second season, and those that were able to finish the first season didn't have surgery in the off season and went back again, still not having surgery, and then compared the two and how they did their second season back. And what they found is that collegiate contact athletes with an in-season anterior instability event, that's the first season, when they came back for the subsequent season, were significantly more likely to return to play if they had surgical repair in the off season and return to play without instability events. So a much higher success rate if you had surgery in the off season, your second season back. Another study that was a little different, and really the findings were a little bit unusual, why in the title they say surprising findings, because these younger high school athletes, South Carolina, underwent non-operative treatment, a large group, about 95, I believe, or 97 patients enrolled on this arm of non-operative treatment. 85% they reported came back the same season and also were able to continue the next season without recurrence. And it may not have been good reporting because athletic trainers and big system, it may not have been as accurate, and it's not a closed system, so give or take a little bit, that's still a very high number, more so than most others reported. What was interesting is the instability type correlated with success. So those that had subluxations versus dislocations had a higher return to play. So what do we conclude from the few studies looking at early return to play? We conclude that there is a high success rate reported of getting back early and get back and play, but there's a high rate of recurrent instability events when you're playing. And if you had your index event was a subluxation, your return to play rates overall were better than if you had a dislocation. So dislocation is a negative prognostic factor. Prior instability risk, or prior instability is a risk for failure as it relates to a dislocation versus a subluxation. Surgical repair at the end of the season did reduce recurrences, and that's well documented, and both in the short and long term. And then finally, the most important thing to consider is, well, you have successful in-season management from a getting back and playing standpoint. Are you doing potentially further damage to the joint? And the studies we mentioned earlier that document progressive bone loss and other lesions is a significant concern, because increased bone loss, and that number is narrowing now as we understand more and more about the stability of the glenohumeral joint. That the number will change the procedure that needs to be performed, because a standard soft tissue Bankart repair won't work for bone loss in even smaller amounts. So are we changing the operation, changing the prognosis? That is a concern, especially young individuals. So my approach, and no one knows what the perfect approach is, but it's important to document on history is a dislocation, subluxation, as we talked about, with their prior events, because if they're frequent and they're anterior, that may influence your ability to, or may influence the recurrence rate, it will influence the recurrence rate and influence your decision to push them in a different direction, not going back, unless there's a unique circumstance. So age, younger sport, collision, position, the ones where you have to do a lot of overhead activities, where you can't wear a brace or harness that might help you, put you at risk. Something to consider when you're talking to patients and seeing if they're candidates to potentially try to get back early. They do need a pretty normal shoulder exam. Range of motion, strength, and stability testing is very important. And stability testing does correlate with failure rates when we return to play. And the one that is the best is the surprise test, which is just the apprehension test when you're on the right there. Supine, you abduct, externally rotate, you push it out, sort of the front is the apprehension test. When you push backwards, the relocation test makes them feel better, but if you take your hand off quickly, they jump. That's the surprise test, and that correlates best with apprehension and potential risk of recurrence. So if that's negative, they have good strength, range of motion, they had a injury where maybe it's only soft tissue, no bone, it was a subluxation event, that might be a one that could go back with lower risk. So imaging.
Dr. Willis?
Yeah.
I am so sorry to cut you off, but we are unfortunately at our time and must conclude.
Okay. So, any questions, or are we all set?
It doesn't look like we have any questions at this time.
Okay, perfect.
So thank you so much for your presentation, and on behalf of Atlantic Health System, Morristown Medical Center, Orthopedic Surgery, I would like to thank you for your participation in today's event. You will now be redirected to the post-event survey requesting your feedback. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. This concludes today's program. Thank you and have a great day.
All right, thank you.